So good morning, and thank you very much for the invitation to speak at your educational meeting this morning. So as Dharma said, what I'll be discussing is recent association guidelines on the use of blood and blood components. Here are my declarations, and I'll be briefly highlighting some of the NIHR-funded trials that are listed here later in the talk. So these guidelines were published back in December and involved a fair number of people and societies covering the scope of our anaesthetic practice, along with endorsement from the relevant allied associations or organisations that are listed there. So this is what I hope to cover over the next 20 to 25 minutes. I'll start with a bit of background. The main bit of the talk will be on some of the key take-home messages, and I'll conclude by briefly highlighting some of the ongoing trials that will inform future updates of this guideline. So why is this important? You can see from these figures that in the UK we use around 2 million blood components each year. The vast majority of this being red cells. Yet, despite those high numbers, there's still a lot we don't know about transfusion, and much of this came out in the wash with the infected blood inquiry. And some of the things that we don't know in particular is how well matched the donor and the recipient are beyond just a simple blood group, how much variation in transfusion practice occurs, and what the long-term consequences of transfusion are. I guess an important question is, do we need yet another guideline? And I'd argue transfusion medicine is a rapidly evolving field. I guess an important question is, do we need another guideline? And I would argue that transfusion medicine is a rapidly evolving field. We've had several practice-changing trials published in the last few years, along with constant improvements in hemovigilance. And as shown in the previous slide, there's been a lot of media spotlight on transfusion, particularly with the infected blood inquiry, frequent blood shortages and amber alerts, and the recent cyber attack in London. Therefore, as a result, I think we felt there was a need for relevant contemporary clinical guidelines that cover the breadth and scope of UK anaesthetist, critical care staff, and allied health professionals. So this slide highlights one of my previous points on transfusion being quite a rapidly evolving field. And if you look at trials focusing on transfusion thresholds, you can see in the last 10 years, we've had over a doubling in the number of trials with essentially a trebling in the number of included participants. Yet, despite the vast accumulating evidence, not just for transfusion thresholds, but for other areas in patient blood management, there remains an implementation gap. So these were the findings of a recent survey conducted by our group. And essentially what we found was around more than half of hospitals did not meet NICE criteria for pre-op hemoglobin testing. So by that, it's usually at the point of referral or testing. And around a third didn't have any peri-op anemia pathways. Only less than half of units had a policy for use of TXA and cell salvage, and around half had access to point of care testing. But I think the survey did highlight plenty of good work equally, and in particular was the role of anaesthetists. So I think in terms of responding hospitals, more than 90% anaesthetists were centrally involved or were in fact leads of various aspects of patient blood management, including preoperative anemia pathways. So this is just a brief overview of our methods. It was a working party with essentially including representatives from different societies. We searched all relevant databases and through literature reviews. We developed a set of 12 recommendations that was through a 3-round modified Delphi process. and it underwent the standard peer review process by the Association of Anaesthetists. And the whole process took 2 years. And I think, again, as I said, it's quite a rapidly evolving field. And in those 2 years, there were several new trials that came out, which sort of meant having to go back, have several discussions again and rewrites off the guideline. And as I'll show you in this slide, since the guidelines have been published, even new trials have been published since then. So getting to the crux of the talk, the three broad topics I wanted to cover were on minimizing blood loss, treatment of major hemorrhage, and transfusion thresholds. Now, in terms of minimizing blood loss, we recommend the use of cell salvage where available and antifibrinolytics such as TXA in patients who are actively bleeding, those in whom you expect major blood loss, and in those who are unable to receive donor blood. Other beneficial or good practice strategies include appropriate management of antiplatelets and anticoagulants, and avoiding excessive blood sampling, using a concept that I like to call smart phlebotomy. So if we start with TXA, and I suspect, and this is probably the most widely studied intervention that I've known, and it's certainly the one that seems to generate a lot of discussion. And here is a list of suggested doses for different clinical scenarios, and many of these have been informed from large multi-center trials such as the CRASH, Woman, and POISE-3 trials. The only scenario where its use is not recommended is in patients with gastrointestinal bleeding. And again, highlighting one of my previous points, following publication of our guideline, a secondary analysis of POISE-3 was published earlier this year, and where they compared patients undergoing general surgery versus non-general surgery. And the general surgery group mostly included patients including HPB and colorectal surgery, and the non-general group was a heterogeneous mix of thoracic, vascular, urology, spinal, plastics, a bit of everything. And essentially, in keeping with the main POISE-3 finding, what they found was that TXA was associated with a low risk of perioperative bleeding in patients undergoing general surgery without any increase in thromboembolic events. And this is data from over 3,000 participants who were randomized. Yet, despite good evidence to support its use, we know that around a third of potentially eligible patients may not be getting tranexamic acid. And if used optimally, it would mean that 147 fewer transfusions per 100,000 people. And our group did some qualitative work to try and explore the underlying reasons for this. We interviewed 22 clinicians, which included 12 surgeons, 7 anaesthetists, and 3 anaesthetic and cell salvage practitioners. And essentially, we identified 8 key influences, which are listed here on the right, and relate to factors such as ease of availability, inclusion of TXA in the WHO checklist, which I think is one of the recommendations from the Infected Blood Inquiry now, and generally improving awareness and education. We also identified specialty-specific risk concerns. We know that uptake is low in certain surgical specialties, such as vascular, when compared with high users such as orthopedics and cardiac surgery. So moving on to drugs that cause bleeding, antiplatelets are a common bugbear that we frequently inquire in pre-op clinic. And whilst we're thinking of what to do and how to manage these, here are some important considerations. So I think it's important to establish what the indication for antiplatelet therapy is. And this is particularly important if they're on it after an acute coronary syndrome, or if they're on it following an elective PCI for chronic cardiovascular disease. It's also important to consider the urgencies of the surgery, weighing up the bleeding and thrombosis risk of the surgery. We've got various risk scores that are available, but I think it's important to highlight that some of these ones that we're used to are poor at predicting major adverse cardiovascular events, and they're not validated in the context of withholding antiplatelets perioperatively. So CHADVAS2 has got poor predictive utility for perioperative stroke, and similarly HAS-BLED for bleeding has got poor utility for predicting perioperative bleeding. So just something to bear in mind if you do use these scores in clinic. And from this slide here, from recent guidelines from the AHA and ESC, the important point here that I'd like to stress is the period of greatest risk following an acute coronary syndrome is in the first 4 to 6 weeks, after which this excessive risk declines over time, reaching a nadir of around 6 months. But the risk is still very much there. And going back to the point I said previously, the indication for a stent is an important consideration. As you can see from this slide, that if it was for chronic stable coronary artery disease, then you can stop or delay surgery for around 6 months. Whereas the latter group, and this latter group can often have dual antiplatelet therapy for 6 months, followed by monotherapy. And if you sort of move towards the right of the diagram, you can see we're entering the sort of zones of uncertainty whereby you have to think if the benefits of surgery really outweigh the risks. So when should you stop them? Again, this is a common question. Again, most of you will know this. Aspirin can be continued in most cases based on pharmacokinetic data. And for the other agents, the recommended stopping times are between 3 and 7 days. Again, what do you do if it's time-sensitive surgery? And a common example that will come across is if it's rapidly advancing cancer and the patient had a recent PCI. And again, as per the common sense and exam answer, you take an MDT approach with this. You'd continue dual antiplatelet therapy if you felt the risk of thrombosis was greater than bleeding. Another option is to de-escalate, so from prasugrel to clopidogrel, or switch them to monotherapy for the duration of the procedure. And in those patients who you think are at very high risk of thrombosis, perioperative bridging is an option. What about regional anaesthesia? So again, there's similar rules to elective surgery, and I think it's important to highlight here that antiplatelet therapy is not an absolute contraindication to regional anaesthesia, and it's more of a judgment of risk depending on the type of block that you're performing and the patient comorbidities. We're beginning to understand that many patients, particularly are non-responders to clopidogrel or have a certain degree of resistance to it. And again, this may open up avenues for more personalized decision making in the future. And highlighted there in italics is the association guidelines on hip fracture, which again clearly states any single antiplatelet medication is not a contraindication to spinal anesthesia for hip fracture surgery. And again, if that is the best option for an individual patient. Just to briefly talk about DOACs, this is fairly standardized now, I think, and certainly our pre-op nurses are very comfortable with this, judging by the lack of email queries that we get. Most are stopped before 2 days, and slightly longer periods may be needed in those with renal impairments and those with a high bleeding risk. We've also now got a slow-growing armory of potential reversal agents, which are listed here on the right. And the main indications for them are severe GI bleeding or to limit intracranial expansion. And the important point I'd like to highlight here is that these do carry a high thrombotic risk. So if you do use them, please consider restarting some form of anticoagulation, even if it's prophylactic, as soon as possible. Warfarin bridging, again, I think it's safe to say, based on trial data, that most patients don't actually need bridging, and the patients that do is just a small cohort of those with mechanical heart valves, acute VTE, TIA, or stroke within 3 months with additional risk factors. So minimizing blood sampling, this has always felt like a bit of an easy win, a bit of low-hanging fruit, but again, it's seldom done for a variety of reasons. The Stratus trial was a study published in 2023, and this was a cluster randomized trial in Canada involving, I think, around 40 intensive care units, where units were randomized to standard tubes versus small volume blood collection tubes. And essentially what they found was small volume tubes led to fewer units of red cells being transfused, which worked out around 10 units per 100 patients. I think one of the concerns with small volume tubes was there would be insufficient volume. And again, what they found was this actually was a very rare, rare occurrence. And based on this trial and other observational data, recent guidance from critical care societies made a strong recommendation for using these in adult ICUs. But again, I suspect this will take quite a while for this to be implemented in intensive care units. So moving on to major hemorrhage, again, this is something that we commonly come across inside and outside the operating theatre. And the points I wanted to highlight is there's now a current trend towards a more pragmatically, clinically based definition based on the clinical states of patients. So the variables listed here are systolic of less than 90 or a heart rate of greater than 110 and judging response to resuscitation. But again, small caveat is that these changes may be masked in certain patient groups, such as elderly patients, patients who are pregnant, and those who are on beta blockers. The rest of these principles are those that you'll be familiar with. So your aims are for hemorrhage control, either with compression in IR or surgical management. Again, important to stress not to normalize, important not to try and attempt to normalize blood pressure and accept a lower blood pressure with volume resuscitation alone. Although this may need to be modified where if you suspect that brain injury is the predominant condition. Hemostatic resuscitation is very much the buzzword at the moment, where the goals are to maintain and monitor hemostasis, restore tissue perfusion, and avoid trauma-induced coagulopathy. And this slide briefly summarizes those previous points. One point that I would like to highlight is that for hemostatic resuscitation, certainly current evidence from trials does not demonstrate clear superiority of using conventional coagulation tests over viscoelastic assays. So those include, for example, TEG and ROTEM. Whilst those devices have been shown to reduce transfusion requirements, no difference in sort of hard clinical endpoints has been observed between either or. Both of them have their advantages and disadvantages, but I think perhaps what is more important is the process of repeated testing, monitoring and reassessment between serial tests, rather than using the results of an isolated measurement to guide decision making. I'd like to highlight a couple of trials in the space of major hemorrhage. So the first is CRYOSTAT-2, which was a UK-led multi-center trial, and this tested the hypothesis that early fibrinogen replacement using high-dose cryoprecipitate, in addition to standard major hemorrhage packs and protocols, would lead to better 28-day survival. Around 1,600 patients were randomized, and the results perhaps disappointingly showed that there was no difference in the primary outcome or in any other key secondary outcomes. Lots of people have speculated as to the reasons why this may have happened. Common reasons include the median time to first transfusion was an hour after arrival in ED. So perhaps you could argue this was not early enough. The treatment was empirical and wasn't guided by fibrinogen measurements. So again, it stands to reason that there may have been a reasonable proportion of patients who may not have had low fibrinogen levels to start with in the first instance. But again, this is a fairly important trial for blood services. The second trial, again, this is bringing it back to the operating room, was this study that was published just a couple of weeks ago in JAMA. So this is in the setting of cardiac surgery, where the authors evaluated the efficacy and safety of PCC versus fresh frozen plasma to treat coagulopathic bleeding in cardiac surgery. Again, over 500 patients were randomized, and the investigators found that PCC led to a more effective hemostatic response which they defined as requiring no further interventions between 60 minutes and 24 hours after treatment. Now, this sounds very seductive, but it requires further thought. We know that PCC is 10 times more expensive than fresh frozen plasma. The difference in blood component used between both arms was relatively modest. And again, there was no difference in hard sort of clinical effectiveness endpoints such as mortality, organ support requirements, or hospital and ICU length of stay. There is a similar UK-led study called Prophecy, which is running, and I'll briefly mention this later on. But again, this is probably a space to watch out for. So I'll move away from bleeding and finish by talking on transfusion thresholds. And again, based on, as showed you in one of the earlier slides, lots of trials, lots of data. It's fair to say that a restrictive transfusion with a target of a hemoglobin of 70 to 80 is safe for most non-bleeding patients. However, there are areas of uncertainty, such as patients undergoing acute coronary syndrome, those with brain injury, and again, that space is evolving and guidance is awaited. Again, another area of interest is looking at the use of alternative triggers for transfusion beyond hemoglobin. So these are physiological triggers. So this is, again, an article. This is the American guidance from a couple of years ago. And just to demonstrate, with all the trials that we've had and that have been completed in this space, the certainty of evidence now ranges mostly in the moderate to high region across a range of transfusion-related outcomes. So these are mortality, cardiovascular events, bleeding, infection, and transfusion requirements. Almost the same can be said for children, and I appreciate I haven't discussed pediatrics much in this talk, but again, certainly for mortality and other transfusion endpoints, the certainty of evidence ranges from moderate to high. So, as I said, areas of uncertainty remain, particularly in patients with acute coronary syndrome. Two large trials have been published in the past couple of years called MINT and Reality. The authors of those performed individual patient-level meta-analyses, which were published at the end of last year. And these included just over 4,300 patients from 4 RCTs. And the primary outcome was death or myocardial infarction within 30 days, along with the range of secondary cardiovascular related outcomes. And you can see here on the forest plots on the right that although the confidence intervals cross the line of no effect, majority of the point estimates tend to favor the liberal transfusion strategy. And certainly for cardiac death, liberal transfusion was associated with better outcomes. Again, looking at the survival curves, so again, there's no difference in 30-day survival, but when they looked at longer time points at 6 months, 180 days, a liberal strategy was associated with a higher survival. What about brain injury? So this was the TRAIN trial, which compared liberal versus restrictive transfusion in patients undergoing acute brain injury. And again, over 800 patients randomized, and the authors found that a liberal strategy was associated with better or a lower rate of unfavorable neurological outcomes. And sort of published around the same time was the Emotion study, which was looking at severe TBI. And again, they randomized patients to liberal versus restrictive. There was no difference in the overall primary endpoint, but again, looking at some of the secondary outcomes, a liberal strategy tended to favor better functional and neurological outcomes at 6 months post randomization. I'll move away from red cells and briefly discuss some of the other components. So we've got FFP, cryo, and platelets. And again, the evidence base isn't perhaps as advanced in this space as it is for red cells. But a couple of points I wanted to highlight were INR prothrombin time and platelet count are poor predictors of bleeding, yet these are the ones that we often use to guide decisions to transfuse. There's no good evidence to support the use of prophylactic fresh frozen plasma, either to prevent bleeding, spontaneous bleeding, or before procedures. And there's a range of platelet transfusion thresholds for low risk procedures. Just briefly talking about FFP and cryo, the main indication for FFP is major hemorrhage, whereas for cryo is fibrinogen replacement. And for both of those, it's in the settings of clinically significant bleeding. These are the platelet thresholds that our guidelines recommend. Again, these have been extrapolated from other patient populations. And a lot of them have been based on low certainty evidence, although that will probably change in the next few years. And again, the important point I wanted to highlight here is to take a risk-adapted approach, and good practice points such as use of ultrasound when performing lines. If you've got a thrombocytopenic patient, perhaps it's best not to let the foundation doctor use that as their first training experience. I'll briefly touch on transfusion safety. Again, it's coming to the end of the talk. It's last but certainly not least. Important points again to stress are positive patient identification, sample labeling. One thing I want to highlight is transfusion-related death is a rare event. So transfusion is very safe, but again, the commonest causes of transfusion-related death have been attributed to pulmonary causes, so TACO-related or delays in transfusion. And there's all sorts of acronyms and slogans on addressing TACO that have been published. So I'd just like to finish up just to highlight some of the trials that you should keep an eye out for, that will be published in the next year or so, and that will no doubt influence future versions of the guideline. So first is the TRACTION study, which is a Canadian study which randomized over 8,000 participants to TXA versus placebo, patients undergoing non-cardiac surgery. That's finished recruitment, and the results are should be published later this year. And the co-primary endpoints were transfusion requirements and safety. Prophecy is a UK trial that's in patients undergoing cardiac surgery, similar to the first two trial I mentioned, comparing PCC versus FFP. And the primary outcome is a composite of those clinical endpoints. Result HIP is, again, I suspect Nottingham is probably recruiting to many of these trials. So Result HIP is in hip fracture patients, and this is comparing restrictive versus liberal transfusion with the primary outcome of death or major adverse cardiovascular events. T4P, so as I said, platelet transfusions are a relative evidence-free zone. So this is a randomized trial in ICUs, and I know Nottingham has certainly been a good recruiter for this study, and critically ill patients will be randomized to one of 5 different thresholds prior to a low bleeding risk procedure with a primary outcome of 90-day all-cause mortality. ABC, again, is an ICU survivor trial comparing restrictive versus liberal transfusion, again, targeted towards more patient-centered endpoints, looking at physical component scores of quality of life. This is hopefully be finishing recruitment later this year. Popeye trial, I have to mention it, given the chief investigator is based in your department, and if I don't, I won't hear the end of it, and obviously it's the best trial. So this is looking at treating post-operative anemia with either intravenous iron plus EPO versus usual care, aiming to recruit 2,400 participants with a primary outcome of days alive and 30 days, days alive at home at 30 days. And again, these, there's still a shed load more transfusion or blood-related trials going on across the UK. So you can see this is a very dynamic space that will evolve certainly over the next 2 to 3 years. I'll just conclude where I'm just slightly running over time. So the guidelines was pragmatic guidance used on the best available evidence. And as I've shown you, there's still a large number of ongoing trials that will inform future updates. What I would say is where there's uncertainty, suggest a risk-adapted approach. variation still exists. Much of, a reasonable amount of it's unwarranted. There's decent evidence to support the use of TXA, but uptake remains suboptimal, as I've shown you, and there still remain challenges with implementation. Thank you for listening. And yeah, if you've got any questions, or please drop me an email.